Good, right? I'm going to use the square needle. And we should point out the square needle. I like that. And I should point out, she knows I hate needles, but I should point out too, I was given the Pfizer vaccine back in March. What we're going now is the booster is Moderna. So tell me about that, because the mRNA, they're basically interchangeable. They are interchangeable now, and with the Delta variant and the Delta Plus variant, we're seeing Moderna is more efficacious against the Delta variant. So going from Pfizer to Moderna is completely okay. We're going to hold on up to it. And after we saw that a couple of people done it today, that's what I'll be doing here today. So, all right, go away. I can't look. Everyone knows I hate needles, and I'm going to see this on camera. It doesn't matter, and I won't feel anything. I can take it right now. But it's one of those things. Are you done? Yeah. I didn't feel it.
Yeah. Hello, everyone. TJ Alls of I-45 now, and that is earlier today as I was at the Galveston County Health District. That is me getting a booster shot of the COVID-19 vaccine. Welcome to a special edition of Healthcare Unmasked. We welcome you all to the show today. And yes, the Galveston County Health District today opened up a drive-through clinic. We hadn't seen that since May, really, those mass vaccination drive-through clinics. But they opened one up today. They had 300 people who had registered already before they even opened up things at 9. And then more came throughout the day. And as it turns out, while we've been hearing things, and we'll talk more about this on boosters and about being immune compromised and the like, there's actually plenty of vaccine. That's what they were telling us on there. And I wanted to make sure everyone got to see that today. So that we kicked that off, just showing it wasn't as bad as much as I hate needles and the like. But welcome to a special edition of Healthcare Unmasked. Normally we'd be doing this at noon, but we wanted to get in a special group in with us here today. And we have from UTMB Health joining us here. We have Dr. Gulshan Sharma. He's the Vice President and Chief Medical Officer at UTMB Health. Dr. Janek Patel. He's the Director of Infection Control and Healthcare Epidemiology at UTMB Health as well. And then we're going to be talking about trying to get in people to work at UTMB, particularly nurses. If you are a nurse, they need you at UTMB. Lori Winslow, who is HR Consulting Services and Workforce Strategy at the University of Texas Medical Branch in Galveston, will be joining us. And then also Dr. Josette, I'm going to get this right, Dr. Armadores Batiste, right? I got close enough that time. Who is the Vice President of the Regional Hospitals and Chief Nurse Executive for UTMB Health. So we have a lot we're going to be covering in the show today, and we'll be taking your questions as we go. Dr. Sharma, let me just start it off with you here. We are at a thing right now. The last data I have, and this was what we have from the health district earlier today, is what we are looking at number-wise here is right now active cases. This is just Galveston County residents. More than 5,600 active cases, more than 126 people who are Galveston County residents in the hospital right now, and we know the UTMB numbers are even higher than that. When we were looking at this a year ago, and before we had vaccines in place and working for this, did you ever expect that once we had vaccines and once we had treatment plans and safe protocols in place, you would be seeing the numbers that we're seeing right now, Dr. Sharma?
Thank you, TJ, for doing this live cast. So I was thinking that after about May, we actually had a thick tail in the third wave, and we were running about 35 patients throughout our health system. And I thought the summer would be nice, and we probably will go through this until probably the fourth wave would be late October. But I was very surprised that I took a week off after about 18 months with my family. So as you know, we've been together since February of 2020. And March 20th, 2020, we got our first case. And we've been here since then. And finally, we were seeing some relief. So I said, okay, let me go ahead and take my family for a week. So we went to Park City last week of June, first week of July. And then the hell break loose by second and third week of July. So I was not expecting this at all. And this clearly shows that how vulnerable the humans are, especially those who are unvaccinated. And I'll probably share with you just to see how we have evolved over the last 18 months so everybody can understand, see how the health system has evolved and how we have seen cases in different waves. So it will help folks to understand. So let me go ahead and share my desktop. This is live data that we have put together since the beginning of the pandemic.
All right, there, and it'll give us a little bit, folks. This is what it does. There we go. And
right.
so Dr. Sharma, tell us what we're looking at here.
So let me give you just overall. So these are the number of positive cases in the Galveston County since the start, 45,787. We have done over 265,000 tests. Currently, this morning, we have 190 patients with COVID who are admitted throughout our health system. I can tell you this is the highest number since the start of the pandemic. And we have total 519 deaths. So we have taken care of over 7,200 patients since the start of the pandemic with COVID. We have currently 31 patients who are on the ventilator, and there are 2 patients on ECMO. And when we look at this, there are 45 patients in-house that have breakthrough infections. That means they were fully vaccinated and they are admitted now with test positive. And I'll talk a little bit more about this breakthrough infection. Let me share some information regarding the pandemic. And I think it's important to look at where we started and why this thing is more concerning. As I share with you, TJ, March 20th was our first case. So this is time on the x-axis. These y-axis is the number of patients that morning in the health system with COVID. This includes both the prison as well as our free world hospital since the start of the pandemic. This was our first wave. March 20th, we started. March, April was first wave. We were running about 70 plus patients throughout the health system. Majority of this was original alpha strain, and majority of the patients that we have in wave 1 were in the prison hospital. So actually our first wave was in the prison side, and we pretty much converted the entire hospital there for taking care of COVID patient. Then we saw a slight decline, and at that time we have no treatments, okay? We were just doing whatever the standard of care was. Hydroxychloroquine, vitamin D, vitamin C, zinc, steroid, whatever we could get hands on in a case report or anything, that's what we were trying at that time because this disease was new to the humans. Now, this is our second wave. Second wave started right around mid-June. So you can see that we peaked around 165, 170 cases, 75 cases. These are all free world. That means it was in Genesee, it was in Angleton, League City, and our Clear Lake campus. And right around first week of June, we got first antiviral approved, which is called remdesivir. And then we got approval of dexamethasone in terms of patients who are seriously ill. So you see that this particular peak lasted about 8 to 10 weeks. And then we saw a lull period in last August, September. We were down back to 40, 50 patients. At that time, the treatment still remained remdesivir early on, then dexamethasone in seriously ill patient. And then we have a third wave. The third wave started right before Thanksgiving. So you can see the uptake in this patient. Right around December 15th, we got an approval, and we actually start vaccinating first dose on December 15th in our Galveston County. First was a healthcare worker at that time. And you see this. Now we are already start seeing an uptake in these cases, and we have around 160 cases in our wave 3, which we continue to provide monoclonal antibodies in outpatient setting because that were approved at that time. And we use remdesivir as well as steroid for appropriate patient in the inpatient setting. By this time, the hydroxychloroquine was completely out. There were multiple studies that came out. There was no benefit for prophylaxis or for treatment with this particular drug. Now, we were going through it. We were setting up our vaccination hub, as you stated, and you covered those nicely throughout the Galveston County. And then we start seeing a decline in cases right after late March and April. We were running about 25, 30 cases in the hospital. Most of them were lingering on for a period of time in the hospital because their length of stay was longer. So this is what we thought. This period what I thought was good. We're going to continue to have about 15, 20 patients in the health system. We can go around, do our work, and we are good to go, let alone we have Delta variant that came about in America, and we saw a very sharp increase in our cases. Couple of things that are unique to this particular peak is, one, it was an exponential growth. So that is one thing. The second thing is these patients are much younger than any previous wave, and majority, if not all of them, are unvaccinated. As I said this morning, we have 190 patients in the health system. One thing to know, we were all talking about herd immunity. The herd immunity about 70% was good enough when you have a transmissibility from 1 to 2 people. Now with Delta variant, the transmissibility is from 1 to 6 to 7 people, just like chickenpox. So you need 90% of your folks have either natural immunity or have immunity through vaccination. And in our area, we are just a little bit above 50%. That is concerning. There is no way you can take care of the pandemic when your population is only 50 to 54% vaccinated. This is what we are seeing, TJ, in the health system in terms of our fourth wave. Now, this particular graph tells you age category of these patients that are currently hospitalized. Below is less than 18 to 50 years, 51 to 64, and greater than 65 years. So we have about 3 patients less than 18, 66 patients in-house that are between 18 to 50. The blue means they are all unvaccinated. And here, 51 to 64, the yellow here means there are 2 individuals here who are vaccinated and had breakthrough infection. And then above 65, you see there are 12 individuals. Now, 4 of these individuals came in for non-COVID related hospitalization, but they were just test positive. One of the things we are noticing in these vaccinated COVID admissions now, they are less sick. They are coming in with some altered mental status, little bit of dehydration. They are not getting into respiratory failure in this particular category. So if I have to say, 95% of the patients that we are seeing in the in-hospital setting are all unvaccinated. 5% who are vaccinated coming in are older, those who have comorbidities, or they could have been coming in for other conditions, not just related to COVID. Our test positive rate in the Galveston County is also going very high, but there is some hope here that the last week our test positive rate did not double. So this was 247, 560, 894, 1393. The concern was if this gone up to 2,800 last week, but it's just about shy of about 1,500. And this week is still open right now. So we will see where the total test positive rate coming from this week for UTMB and Galveston County. These are specifically patients who got tested at UTMB. Now, there are other facilities that are testing. We are monitoring our data internally at UTMB. So TJ, this is kind of what I want to share with everybody, that current pandemic is mostly of unvaccinated individuals.
And again, let's the number you'd said and is 95% of those you're seeing in the hospital are unvaccinated and younger than
Correct.
What we saw before. The vaccinated account for 5% and older, and these are the most current numbers that we have from the UTMB system. And we hear a lot about breakthrough cases in here, but of the breakthrough cases that have been seen, and this is folks in the hospital, we should say, 275 COVID positive breakthroughs with the UTMB system. Of those, 22 ended up in a hospital setting, 2 of those in the ICU, and then 1 death. And as I understand it, those are the most serious were older people who had been vaccinated for that. But it's still less than 5% of those who are vaccinated that had the breakthroughs that are coming in there. It really is. If you're unvaccinated, the chances are you're more times likely to go into the hospital.
Absolutely. And I think that is what I want to share with everybody. I know there is a lot of conspiracy theories going about virus, where it came from, what treatment to use, whether we should use A, B, C, or D. I think one truth that I can say in the 19 months that I have learned, these vaccination really prevents severe disease that will lead to hospitalization or death. The vaccination are not to prevent true infection. And I can explain to you a little bit about this. These vaccination are, we get a shot, we make antibodies against that. The true vaccine that's going to prevent from infection is going to be intranasal vaccine, and that is currently under development. So if you have a nasal immunity, that is what's going to truly prevent you getting infection down the road. But what is really important for us is to reduce the risk of getting severe disease and dying from this virus. And I understand that a lot of people look at the denominator. They keep looking at, oh, there are so many people who are infected and very few people are dying. But it is after the fact. And I tell everybody that yes, I love statistics. I love all that. But for you as an individual, TJ, you only have two outcomes. Either you live with virus and you do fine, or you're going to die. So it is 0% or 100%. And it's going to be after the fact. You're not going to be 2% or 1% death for you. So I think one thing I really want to tell people that we should really think about as an individual, what is your likelihood that you're going to get this virus? If you're unvaccinated, you're going to get serious disease and you're going to get intubated and currently going to get into may do better or may die. So currently the data is 20% of those who are test positive get hospitalized. So 20%.
And that's the number and again, I agree with you. Early on, there was a lot of focus on the number of folks who tested positive and then the number of folks who died. Now, with anything, obviously, and this is, as you learn about it, I know at one point we have made the decision to stop running those daily numbers.
Yeah.
Because I felt at one point it was not doing anyone any good. It was actually confusing people more than anything else, and particularly, and that's why we went to more of a doing it once a week and taking a look at where our trends are. Mm-hmm. And Dr. Janek Patel on with us now too. And Dr. Patel, that's also what you do as an expert on this, is that particularly since infectious diseases that's your wheelhouse, is that you look at it not as what we're doing daily, but you look at it over a course of time, like what Dr. Sharma just showed us. You look at these waves of that. Can you explain why that's important to look at things from that perspective and not the day by day as if it's a football game?
Well, I mean, we really have to understand what's going on in terms of what's going in our environment. We have to actually foresee a little bit in future. So looking at the waves, we're looking at the daily numbers, looking at the daily positivity rate, whether people are symptomatic, asymptomatic, whether they are being hospitalized or not. I think it allows us to plan for the day, but also can allow us to change our practices, our policies and procedures, our messaging to our patients as well as to our own staff. So we really have to have this global view. And I think we even look beyond our local community data. We look at our regional data, we look at our state data, we look at national data, and we look at what variants are circulating where. It's really, you have to have a 3D view of this pandemic in order to respond today and actually to plan a little bit ahead.
And the vaccines you're seeing here, this is Greg Reicher, the Justice of the Peace, Precinct 1, who, by the way, when we were talking about breakthrough cases, he is one, by the way. He went on vacation in Mexico, came back, had an infection, but says he lost a bit of a taste and smell. Those are the only symptoms. But he says if he had not been vaccinated, he thinks it had been far worse. He is immune compromised, having fought cancer off. And then today came in and got his booster shot as well. And so one of the things, Dr. Patel, if you can talk about this, because one of the questions is that comes up is that what's a mutation? Because we give these things names, but as if they're their own thing. But they start off as COVID-19, which is a SARS virus. But can you explain what causes a virus to mutate and why that's important?
Well, viruses mutate all the time, and coronavirus is no exception. And the mutation often happen very randomly. But based on the host or the person the virus infects, the immune pressure, the other environmental factors can determine which mutation has a survival advantage. So again, viruses of all kinds mutate all the time in order to, just have a survival advantage. So the mutations, of course, happen at a genetic level. This particular virus, the corona SARS-CoV-2 virus, is actually an RNA virus. So the RNA sequences have random mutations. And as I said, it leads to certain proteins that are expressed, and then they may be important for the virus to become more aggressive or to survive. There are all those things that are happening. And so mutations can happen in face of medications you use, in face of vaccinations you use. And so, again, and certain mutations, like we met, Dr. Sharma was mentioning, the Delta mutant we have right now, the property it has acquired is that it infects very, and it also replicates to a very high number, very high copies in the nasopharynx. So it also that's why it transmits easily, and also it makes people sicker faster because the high virus load leads to. So mutations can have different properties.
And Dr. Sharma, let's get back to that, as you had pointed out, because I for those that may not have heard that, and by the way, folks, you're watching a special edition of Care Unmasked presented by UTMB Health. I'm TJ Alt of I-45 now. We have on a great panel here in the experts who have been, quite frankly, fighting on the front lines of against COVID-19. And I will tell you, as someone who is always looking for information, these two gentlemen you see on the screen here are two men that I talk to on a constant basis. When you talk about get educated, these are the guys that educate me on a regular basis, along with Dr. Kaiser, and talk with them. And again, let's talk about how Dr. Sharma, how much the Delta variant spreads versus what we saw before, and how that is different.
Yeah, so I think that's what Dr. Patel was saying. The way the variant comes is, if the virus does not replicate, you won't have mutation. And the virus is only going to replicate if it infects you. So if it infects hundreds and thousands and millions of people, you can see this virus is churning the machinery, and there is going to be some break because the viruses are dumb. So when they replicate, they're going to take few nucleotide off, and they're going to add few nucleotide, and you never know which is going to be the next mutant that's going to come up. So the only way to prevent mutation is stop replication. And the stop replication means stop transmission. That's the way to look at mutation.
And that's the stress on, obviously, vaccines, which is considered now the first line of defense, but also social distancing, face coverings when you can. And as I understand it, from what we've talked about for more than a year now, is that these steps is what prevents the spread, which is what causes the mutation. The mutation doesn't just happen on its own out in the midair. It's attached itself to someone, and then from there it mutates. It has to have to use a sci-fi term, it has to have a host.
That's right.
Essentially. And then that's when the mutation comes in.
That's right. And the host for this virus is humans.
Right.
And I think that's the tricky part. And so to talk about the transmission, so what happened is the original virus. So if I get infected with the original virus, and if I'm coming around within the 6 feet of other individuals or coughing or sneezing, I could infect 1 or 2 more people. Okay, that was original strain. With this particular strain, if I had the Delta variant, I come across in large gatherings, I could infect 6 to 8 individuals, just like chickenpox. And that is the concern here, is why the immunity that we have, 52% vaccination, is not going to work with Delta variant, because you're going to have a lot more people who are going to get infected when they come across somebody who had this virus. And that's why we need 90% immunity to get hold of this Delta variant. So currently what we are thinking is that 4th wave is already going. It's going to take 8 to 12 weeks to go through. That's how much each wave is, about 8 to 12 weeks. Okay. Our goal, TJ, with your help, is let's prevent the 5th wave. That's the goal for us. Because if this virus continues to mutate, it could go one or the 2 way. The 1 way would be it goes to this mutation where it is not transmissible and it's going to die out. Okay, that could be one optimistic look for this virus. But the second look of this virus is if it mutates and now you have another mutation that is highly virulent than the Delta, then we're going to infect much more people. And I think that's what our concern is. The time is of essence here. And I would encourage everybody who is not vaccinated, we can definitely help get them vaccines.
Right, and it's available and it is free. Yeah. Again, as you saw when we began the show, folks, today the Galveston County Health District opened up the drive-through vaccinations. You just have to go online, register, and do that, and go through. It's open every day, 9 to 3, weekdays, I should say, as well. And again, no one's requiring you to do it, but you can get out there. Let's talk about the vaccines, though, because a lot of attention paid because this is the kind of the first that we've seen mRNA vaccines come to the front on this discussion. And while it has been talked about for years within, our what we will say talked about within the medical community, it is not something that the general public is very aware of. And I'm going to zoom in on this a little bit better here so we can see it. And I was going to leave it up to you here first, Dr. Patel. Tell us, how does an mRNA vaccine work? Okay. So that we can understand, because folks have an understanding of vaccines. Like they say, well, it's really, it's a dormant part of the virus and they putting that back in you. And there's always these names, but what is an mRNA vaccine? How do they work? And what makes them more effective that we're seeing right now?
Look, TJ, that's a very important question. And it, in fact, people not understanding this whole technology is the reason why we have a lot of, alternate theories and, myths. So I think understanding this is critical to vaccine acceptance. So first of all, mRNA, is part of any, but in this case, a COVID virus, right? mRNA is part of the molecular, I would say, genetic code that eventually is transcribed into creating proteins or other parts of the viral, envelope and other constituents of the whole virus. That's known from the very first coronavirus that became important. That was the SARS virus about 15 years ago. Fortunately, people had done some research over a couple of years and found out that there is a part of that virus called spike protein. It's very important for the viruses to, again, attach, infect, and cause all the damage in the host. So,
and before you go on there, I think it's important to note here, a little pat on the back to UTMB officials. A lot of that protein research and that discovery came a lot from UTMB Health. Dr. Shi and I were talking about this a year ago. Identifying that was so key. Yes. Along the way. And so I wanted you to kind of stay on that a little bit, how important it was to pinpoint onto that protein spike.
So that's right. So what happened is that we had known that this protein would be important. So as soon as the COVID-19 virus genomic sequence was identified, which happened very quickly in early part of January, our scientists and others zoned in on part of the virus, again, genetic machinery, the RNA, that codes for the COVID, the spike protein. So in order to develop the vaccine, what they have done, they have synthesized this artificial RNA in a test tube. It is not taken from a live virus. So you can have machines, you can have synthesizers in the laboratory that can create this RNA sequence that only codes for the spike protein. It is not the whole virus RNA at all. So again, we had this fortunate situation where we had known spike protein would be important from old research with other coronaviruses. And so once this was done, people quickly tested it to see if you immunize an animal against it and it produces the antibody that neutralizes the virus. All those experiments were done very quickly. So anyway, so what's happening for human immunization is, first, you have this laboratory created piece of RNA that is very small. It's not a whole virus, does not come from a virus. And then these RNA are very stable. And so if you just leave it in a test tube, it will denature in matter of seconds and minutes. So you have to stabilize it. So the viruses, the RNA sequences are stabilized by putting in special, formulation that includes lipids and other chemicals so that the RNA is very stable in a test tube. Also, it's stored at a very low temperature. That's why, when the Pfizer's mRNA vaccine first came out, we had to store it at minus 80 degrees temperature. Moderna, the way they have packaged their own RNA sequence, it survives at a slightly higher temperature. Anyway, when you inject these mRNA through a needle into your muscle, the RNA gets delivered into a cell, your muscle cell, basically. And muscle cells then pick up this RNA. Now, RNA can never really go into your DNA, which is our original genetic material for humans. And that's what we pass on to our offspring, right? So the male and female, the chromosomes are all DNA. So the RNA cannot go into DNA and change your own genetic makeup, get into your sperms or in your eggs and affect fertility and other issues. No. RNA stays in the outside part of the cell called cytoplasm, and it uses a cellular machinery to produce the spike protein, for which it codes. So once the spike protein is produced by these cells, for example, muscle cells, it is released and then is picked up by your natural immune cells, usually T lymphocytes and B lymphocytes. And then it is these cells that eventually produce an antibody then that fights off the infection when you are exposed to the virus in the future. Now, if the mRNA that you inject into the muscle cell, as soon as it transcribes the protein, it actually is denatured by cells' own other enzymes. All cells have RNase enzymes. And so it cannot escape the cell. And even if it escapes, the cell is taken up and quickly denatured in blood. So it does not spread in the body. It doesn't go on, damage other organs. So, because people have a lot of fear about this RNA somehow integrates into your cell and then you can pass it on to other people. It will cause infertility. None of that is possible. And that's how this whole RNA vaccine system works, TJ.
Thank you, Dr. Patel. And where it gets into is understanding how that works is the technology. It's there. And obviously, one of the things that comes up, and we hear this from detractors, and we're seeing this right now, is it's emergency authorization. I know that talking with Dr. Philip Kaiser, our local health authority, who's a cohort of both of you, he has said he is frustrated how long it has taken the FDA to give it full authorization. Although right now that seems to be sped up, and we may see that as soon as September. Are you surprised it's taken this long, given what we know now, and given the technology that we don't have what's holding some, or they claim this is what holding it back, a fully authorized instead of emergency certified vaccine at this point?
So first of all, TJ, this was a global emergency, right? So we had to create things under urgent condition. So there is no doubt. I mean, we could not go through a normal process of a product development that takes years, okay? Otherwise, we would be in big trouble. So emergency use authorization, that means you can initially, test out the product in a clinical trial setting. But once you have certain amount of information that is promising, produces the desirable, for example, in this particular vaccine, produces desirable amount of antibody, and it's not harming the original research subjects, and is even providing some protection, the FDA, they will give an emergency use authorization. Now, the final authorization takes into account a huge amount of experience. That includes safety signals. It includes efficacy across various conditions. In this case, for example, the virus mutating. Also, emergency use authorization includes the entire manufacturing process, okay? That is production facility. They have to go and inspect it. They have to look batch quality control. So there are a lot of pieces to it. So for the initial phase of emergency use authorization, FDA does not focus on that manufacturing aspect of it. It only focuses on initial safety and some efficacy signals, and then it lets it be used because this is an emergency. We are in a pandemic. So they would like us to test it out in real world situation. And as more information accumulates, they will look at the information. Then they have to go to factories and look at all this manufacturing process. So it's going to happen. We are told in matter of month or two. We don't know exact timeline, but it's it's now around the corner. Now, by the way, even under emergency use authorization, we have tons of information that far exceeds full authorization of a lot of products we use. Okay, including many other vaccines that are currently acceptable to people. So we have given over 1 billion doses around the world, right? In this country, we have collected so much safety information. So all that is available to us to feel safe about this vaccine, even under emergency use authorization. TJ? Gulshan, do you want to add anything?
No, I think you said it succinctly, and we probably TJ will come back and join us.
What I wanted to do is I brought up here. This is Mike Allred, one of our viewers here. He says, "I personally choose not to take something in a test phase." This goes to a lot of what you were just talking about, Dr. Patel. But more power to those who choose to. One of the things is that right now, if someone were to go into the hospital and be outside of proning, are any of the therapies or treatments fully authorized by the FDA at this point? Or are they also under emergency authorization?
So I'll say a few of these examples. And Dr. Sharma has experience with many other therapeutics. So the antibodies we use, right? Once you get sick and you're a high-risk person, we use antibodies to actually prevent you from going into a more worse situation. And we reserve them for high-risk individuals. Those antibodies are also under emergency use authorization. The governor yesterday, as this topic today, governor was found positive 2 days back, and he got the antibody. That antibody is under emergency use authorization. Dr. Sharma mentioned remdesivir when we first started. It was under emergency use authorization. I can tell you, TK, even we have people who do not want to get vaccine under emergency use authorization. I'm telling you, any patient that is hospitalized, okay, and we have used emergency use authorization medical, nobody has refused that. Nobody's even asked a question, okay? And so we have therapeutics that are under emergency use. We use them to save lives.
Right.
Vaccine.
And that's not, by the way, that's not uncommon. You just pointed that out, not uncommon. And speaking of using to save lives, we're taking a look now. This is video shot this morning, thanks to Chris Gonzalez at UTMB Health. This is in the ICU unit at UTMB Health, where, as we pointed out to you, more than 100 people in the Galveston County residents alone in the hospitals right now. Not all in UTMB, but the numbers in UTMB, just in Galveston right now, there are 226 total patients, 71 are COVID. At John Seeley, 125 total patients, 8 are COVID. At the Clear Lake campus, 133 patients, 48 of them are COVID. 104 total patients at the League City campus, 53 are COVID. And then in Angleton, 37 total patients, 14 are COVID patients. Not all have made the ICU, so I don't want to give anyone the misinterpretation here. But and this will lead into our next segment here. But Dr. Sharma, you're the chief medical officer. How busy is it in those ICU wards and the hospital overall because of COVID?
Yeah, TJ, I have not seen anything like this. So in our normal times, so I would have 20, 24 patients in the ICU that we round, and maybe 4 or 5 are intubated out of them. Currently, we have 29 patients on our ICU at Jenny Seeley. ICU patient, 24 of them are COVID and 18 are intubated. And it is a lot of stress on the staff. And I have not seen anything like that. The staff is exhausted and they've been working so hard. You see all the PPEs and everything we have to wear to go in each time to take care of these patients. And one of the really struggle with the employees is that these young nurses are young and they see these patients that they are taking care of them are their own age. And they lose them. And I think it is really a concern for them, for their own well-being, that what they are seeing, that this could be preventable. I can imagine, early on in the disease, we didn't have anything. We were all learning. We are supporting each other, masking, social distancing. We shut down some of the businesses at that time, as you recall. Now, after the vaccine, I understand we have right of choice. I totally get it. And I'm all for right to choose. But I think this is a preventable, communicable disease. It's not just going to impact you. It's going to impact 5, 6 other people around you when you get infected. So that is kind of what I'm trying to say, that, things were very different when we were just getting these vaccines approved. But since the vaccines got approved, now most of it is now man-made pandemic in our region. So if we get more people vaccinated, this could really go down very quickly and we can resume our normal lives very soon. And I think that's what we want to tell folks, that let's not extend it longer than it has to be. The Spanish flu pandemic was 3 years. We didn't have anything at that time. It just goes through. Only way the pandemic ended was suffering and sacrifice. At the end of the pandemic, 60 million people died worldwide. And we learned a lot over the last 100 years. We have huge accomplishment in the science world. And we talked about that. This vaccine was truly a moonshot for the scientific community. And we wanted to do that, but we miserably failed. I think it's a failure in terms of that we were not able to curtail the pandemic sooner than what we should. I think 15 months, now we are into 19 months of this pandemic. And in the foreseeable future, I don't see anything moving in the right direction at this time.
And I want to give a little context to folks who are watching here to see. Now that is one of the rooms at Jeannie Seeley, or is this John Seeley?
Jeannie Seeley, I see.
Yeah, there's Jeannie Seeley. And yes, it's empty. And folks will say right off the bat, well, see, look, there's plenty of room. And when we say about ICU room availability, for example, can you explain that, Dr. Sharma? Because it's not just the physical room, and that's what's going to lead me to talk to Lori here just a little bit as well on this, because it is not just the physical room that matters in this case.
So the ICU beds need a lot of equipment and a lot of staff to run a patient. So you need a respiratory therapist, you need a nurse, you need a PCT, you need physicians to take care of the patient who are in that bed. So it's not just having a bed. You need the qualified and skilled staff who can manage these patients. You are absolutely right. At any given day, TJ, we have about 30 patients waiting in the ED for a med surg or an ICU bed. Usually it is about 30% ICU beds and 60-70% med surg bed that the people are waiting for 24 to 48 hours in some cases to get to the bed. We manage them as well as we can in the ED, and we try to move them to their bed once the bed is available, as well as we have the staff to actually take care of those patients.
And you're looking at one of the staff members now. This is from this morning. This is was shot there. That gives us a chance now to bring in our next guest, and Dr. Sharma and Dr. Patel. I want you to hang loose because we're gonna have you guys come back on here shortly to answer some questions. Now coming on with us, and we're glad to have these two ladies on with us as well. First up is Dr. Patel, who I introduced earlier. She's the Vice President of Regional Hospitals and the Chief Nurse Executive for UTMB Health. And then also Lori Winslow, who is the Director, HR Consulting Services and Workforce Strategy at UTMB Health. Thank you both for being on with this. Does that right now, what are the I put the question this way: where are heroes gone? You saw that sign that was up earlier. All those, thank you for what you've done for us there in the ICU. We saw a lot of those, and we saw the signs all over UTMB earlier, last year, and then in yards and everything else, where for the first time in a long while, medical personnel, particularly nurses, were getting recognition. So I've got to ask, because we got a shortage going on right now. Where are all of our heroes right now, and what's the cause of that you're seeing? And what? And first, let's just ask, not only ask that question, and then we'll follow up with that.
Sure. So right now, as a nurse, there are many opportunities to work in various areas. There are staffing agencies that are paying a lot of money to nurses to travel nurse. So many nurses take that opportunity and they've gone to do that type of work. So that's where the staff have gone.
Yeah, it's you find UTMB and others are competing with hospitals across the country to get the staff in. We know that the Governor Abbott last week is implementing getting 2,500 nurses on the ground levels in high impact areas. But from what I understand from you and other experts, 2,500 won't even put a dent in what is needed right now.
That is correct. And, just to also make a point that UTMB has not received any staff from the state.
Yeah, so recruiting has got to be a tough one right now. And Lori, that goes into your wheelhouse now. Lori, what are you doing to get folks in? It's got to be tough. You and I joked with you when we first came on. I was surprised you were still awake because I would think you're up 24/7 trying to recruit folks to go to work at UTMB right now. And as you're talking, I'm going to pull up some nursing numbers because we looked at the statistics last year to this year. And it was compelling to me. But what's being done to get the help that you're going to need at your facilities? Because we got a lot of folks here at UTMB. They think just Galveston. It's 2 hospitals in Galveston, 1 in Clear Lake, 1 in League City, 1 in Brazoria County, plus the prison hospital on top of that. Mm-hmm. Plus, if you want to take about real staffing everywhere else, you got all the clinics and everything else. But so because I guess one of the things, let me ask you though too, is part of this was last year. Right before this time, a lot of it was, all right, we're not doing anything but COVID in the hospitals, mm-hmm. which was financially detrimental as a kind of an internal shutdown of a lot of things. Now it's a mix of both. Is that one of the things, and Josette, you can answer this too, is that one of the demands now is that we're seeing is it's not just COVID, it is COVID, broken legs, heart ailments, and the like as well?
Yes, we are seeing all of those things in addition to COVID.
And Lori, what are you doing to recruit folks? Because that's got to be a tough sell for anyone right now. But I talked with a nurse before we came on because she called me, and a friend of mine, and she said, "Listen, I've already gone through this. I can't do it anymore." Mm-hmm. I want to know how much burnout is coming into this as well right now.
There's a lot. I've been in this market since 2000, specializing in healthcare for about the last 20 years. I've never seen it like this. We've been in a pending nursing shortage for quite some time. This pandemic has just exacerbated the situation. You combine that with the opportunities, not just across the United States, but even globally. Where people are taking an opportunity to travel and work for very, very substantial sums. And that's just pulling more out of this market. The governor's 2,500 allotment that he has approved, the majority of those went the first couple of days to El Paso and Dallas. And I know in this area in Houston, we've had and with this variant, more of an impact to the pediatric population than the original COVID. And so we don't see a lot of support at all in those state numbers for pediatric or for emergency room nurses. And so those are 2 areas that we're really focusing on. We've been having lots of new resources coming on board from advertising, doing a lot of social media, reaching outside of this market, pulling from across the country, having virtual career fairs. We had one 2 days last week in partnership with Josette and her team, and hired, I think, around 60 staff across a number. That I considered that a great success.
I was going to say 60 right now in a recruiting class. I would think that's pretty big.
Yes.
I compare that to about 2 months ago. We had our first, what I thought was going to be our first slate of career fairs, that when we saw the numbers from COVID really going down, we hired about 100 across 2 days at that event 2 months ago. So, and I've augmented my recruitment teams, both on the staffing side that does short-term staffing and our internal talent acquisition team. And I've got probably an additional 6 people that have been focused strictly on sourcing clinical staff. Right now, this week, I've got about 430 openings of critical health system needs that are frontline staff. At least half of those are nursing.
Yeah, back that up. Tell me the number again. How many positions do you have open right now?
Just for the critical needs in the health system, it's exactly 426 as of yesterday.
426, and so a little more than 210 of those are nursing positions.
Yes, and there's respiratory therapists, there's lab, there's all of those ancillary services that are absolutely critical to caring for all of our patients, but especially our COVID patients during this time.
And I want to bring up some numbers here, and Dizzy Marlowe pulled these up for us, and did it quickly, by the way, when I started asking this question. Let me pull this up and take a look and have you two look at the screen. This is a comparison of 2020 to 2021. This is includes total count of employees. This is part-time and full-time, including those caring for COVID patients. And so you have 2020 on the left, 2021 on the right. ICU that you had a med surge to start there, 469 last year, 485 this year. So you go, oh, well, there's more. We're doing good there. But you got to understand the demand is higher too, is it not? That's the thing too, Josette and Lori, is that, again, last year, COVID, that was about the only thing happening in any hospital anywhere. Now we've got to get back to cardiac. We got to get back to orthopedics. We got to get all sorts of stuff that are still just as important. And
that's also not taking into account the bed capacity expansion that Josette and her team have been focused on across this last 19 months to get us to a place where we can continually care for more patients. And as Dr. Sharma demonstrated, the number that are inpatient is greater. That we need more care staff because we've got more beds and we have more capacity that we could create availability through if we had staff who could cover that.
And that's the key thing. A room can't run on its own.
Absolutely.
And normally, and Josette, correct me if I'm wrong, normally, particularly in ICU, you want one nurse to 4 patients max.
In ICU, 1 nurse to 2 patients.
To 2 patients. Okay.
Yes.
So I doubled it up there. So 1 to 2, because this is not an ICU patient. It's not like, oh, I can come check on you every once in a while. There's a reason it's called intensive care.
Yes.
But even that has to get stretched at sometimes. And,
it does.
And so every shift, you got to have 1 nurse for 2 patients. If you've got 20 patients sitting on a ward, an ICU ward, you need at that time, how many nurses for that?
If you have 20 patients in ICU, you need 10 nurses to take care of those patients.
On every shift.
On every shift.
Yeah. And so, and then, there's, and I can't, and you explain this, how many shifts run in a day?
Really there's 2 shifts. There's an A shift, which is 12 hours, and a P shift, which is 12 hours.
But you also had to count in rotations and everything else. So that the number of bodies you need is just so much more demand when you're talking about ICU.
Yes. So, and in addition to, just to put a little more context around it, we're budgeted for 610 beds. And today we're running 754.
And that's system wide.
That's system wide.
That's Clear Lake, that's League City, that's Galveston, and that's also Angleton, Danbury. There.
Yes.
The number that it strikes. So when you see it goes, oh wait, there's 291 now. It was 277. That does not take, well, you pointed out, does not take into account capacity has increased, other things to care, other people to care for. Here's the one, and explain to me here, COVID MS, and then there's COVID ICU. I guess COVID MS, that's medical
med surge, medical surgical unit. Mm-hmm. Yes.
Last year at this time, 231 on staff. Now 135. That's got to be a frustrating thing for staff, because that tells you right there where it's roughly 100 less staff in
Yes.
that COVID area, and you've got more patients than you did a year ago.
Yes. Yes.
And then ICU numbers are about the same, but just as we talked about. So again, folks, the numbers are the numbers. This is what it takes to do that. So I think there's a disservice a lot of times to say, oh, number of beds. People hear that, and the common person will say, oh, well, they just put them in another hospital, build more beds. You can have a totally empty hospital if you have no nurses in it. You're not putting anybody in that, and that's the challenge for you right now, is it not, Lori?
Yes, it's every time we have any event, all of our recruiters center themselves around the fact that even if it's one person, two people, whatever that number is, if we can hire anyone, that is someone that is going to be taking care of a patient that we can't take care of today. I will say that my team keeps mission first, but it's affecting them too, just because they're so good. I've got tremendous tenure here at UTMB. They know this market. They know Josette and her team very, very well. They represent us beautifully, and they just keep going out there. And the numbers of people who are available are diminishing. And so I know that there are people who left this market to go out and travel over the last several months in other states. And
travel nurses, not just travel nursing.
Travel nursing.
And
it's nursing, and it's respiratory therapists, and it's even LVNs and some MAs, just depending on where the different states had opportunities. For those that are local, I invite them to, I think I provided you with a website and a QR code. If people would like to look, we have got opportunities with UTMB. That link will go directly to our job site, and you can look at full-time roles. We also have a healthcare system staffing division that is part of the health system that allows us to hire contract staff that are just to be used as needed. And so we've got probably 50 or more opportunities there for short-term contract staff. But all of these, everyone in the market around the country is getting creative with incentives and different pay plans and all sorts of things. So we are determined to be competitive and sit down and meet individuals' needs and come up with an offer that is attractive for them to say, you know what, I'm not going to travel. I can stay home and receive that same type of compensation during this crisis period and work at UTMB.
Yeah. And
we want to see those people, please.
Right. Yeah. Send them right away. And if you're watching this or you know of anyone, there's the QR code there. We'll also post this up within our feed as well. Sorry, it took a while to get on up there. It took a while, but also you can go to utmb.edu/HR/careers to find out more. Are you having to entice with signing bonuses and what type of perks are you having to give right now just to compete with what's happening right now?
So we are limited as a state employer. Right now, we are not able to do sign-on bonuses because of state code, but we are able to do incentive bonuses for critical shift in forms of pay practices. And so Josette and her team have worked very closely with our business partner team and put together a critical staff incentive plan for our current staff so that they can also receive additional compensation for doing this crisis work. And we've also applied that on the HCSS side. And we are able to do both hiring bonuses and conversion bonuses for people who work a 13-week contract through HCSS and then accept a full-time role with UTMB. So we are very creative and have a lot of ways of crafting a very competitive offer for our local teams.
And someone had just texted us they wanted a better shot of the QR code, so I'm putting it in a little bit better position for
Thank
them.
you.
There. Thanks for our viewer who did that. So, and we could keep going for that, but I want to get in a chance. And again, full disclosure, I always love talking to folks in the nursing field. Obviously, I am biased here. My aunt is a professor in the graduate school over at UTMB Health School of Nursing, has been there for many, many years. And in fact, anytime I'm in the hospital or if I'm in there, I always ask, let's say, well, where'd you go to school? And my wife, being a college president, obviously has nursing programs, and so it's always an interest. It's a special place in my heart. Bias. I like the nurses better than I do the doctors. Sorry, Dr. Sharma and Dr. Patel. You guys are my buddies, but the nurses are a lot more fun to deal with than on the other things. I'm just kidding you too. But again, if you are a nurse in there, and I want to ask Lori, I mean, because you mentioned at the beginning of this, there was a shortage to begin with. Let's forget COVID. That every college, every community college, everyone is trying to crank out a nursing program everywhere. We just and they're trying to do the dual tracks. I know at University of Houston, Clear Lake, and Alvin Community College, for example, so you can get on beyond, so you can do a dual track and get into the field faster and move on. But how far behind are we before COVID, and now how much further behind because of the demands that are going on in the medical centers right now?
Well, it's, I think before COVID, we were looking at a cliff, I'll call it. As you look at the baby boomer generation that, has started retiring, and doing a projection out to, I think it was around 2028, I believe, is the target year that I've seen previously, where you see that huge number drop in terms of nurses available in the market, because by that time, the majority of them from that demographic will have retired or have moved out of a patient care role. And so we've been preparing for that and looking at different avenues, different solutions to partner with local high schools and community colleges and get our staff part of those workforce development plans, get people from the community. Josette has done a beautiful job working with GISD with a summer program that we have where we brought their students in. We weren't able to do it last summer, unfortunately, but 2019, we brought in, I think it was around 10 high school students who had an interest in health careers. And she was able to offer 6 of them at the end of the summer and bring them on as hospital aides with a 6-month intensive training plan that then promoted them to a PCT at the end of 6 months. So these are brand new high school graduates that are put on a very, very nice healthcare career path, and then provide them with our education reimbursement, tuition reimbursement program so that they can continue and go on into nursing or other health careers. So we're trying to grow our own right now with the pandemic and the effect on staffing across the globe. It's just very competitive, and I'm trying to appeal to those people who've gone out, had that stint with travel to make the money, and you get to a point where there's that rule of diminishing returns. How much is it worth to you to continue that? And so I've talked to several in the market over the last few weeks who've reached that point and said, I need to go back and have a home.
I liken it to it. And I have some good friends who are travel nurses, in fact, and they always, and I've talked to them recently, and years ago, they're talking about, oh, this is the greatest job ever.
Mm-hmm.
Now they're just like, I want to come home. I mean, what I hear from them, and I liken it to, and I can't compare it to the real work that nurses do. I liken it to, I used to be the senior producer of the Houston Astros TV network. So I got paid to go to baseball games and travel around the country.
Mm-hmm.
There was only so many hotel rooms I could see and baseball stadiums I could see. After a while, it became the same thing. And I came home. Now, again, I wasn't doing real work compared to nurses, but I get the travel aspect of it loses its luster, I think, for some people.
Well, the effects of this pandemic on our staff, as Dr. Sharma was talking about earlier, psychologically, physically, it is very difficult. And so, when you think about a traveler, you're going for, usually 2 to 3 months to a strange location to work with strangers, and you're still doing the same work that our people are doing here, but you don't have that internal family connection with the health system. And so it just exacerbates the effects of the pandemic for them as frontline workers.
I want to thank you all. Now it's our last segment of the show, and as I said, we could keep going on and on and on. We're going to take some questions from our viewers here for the next 15 minutes or so. I'm going to start off with Stephanie Kimmerling, and I'll read this to you, and anyone can chime in at any time here. I hear a lot of people hesitant about getting the vaccine because they previously had COVID. Can you please speak to breakthrough infections in those who had natural disease before? And I think this is about having natural disease and then getting again, not having been vaccinated. Also, can you speak to any evidence the future mutations may affect children more severely, which we're already seeing with Delta? You talked about that. And Stephanie must be a president of the fan club, Dr. Sharma, because she thanks you personally before asking this question. So how about it, Dr. Sharma? Because you talked on this a little bit. Let's go ahead and dive into this a little bit more.
Yeah, I think we have discussed this previously, and Dr. Patel can add to it. You don't get that robust antibody response with natural infection. So that is why even folks who have COVID, you need to get vaccine because you have a much better immune response to these vaccines than to natural infection. And we have data that people have shown that your antibody production is not as high as you would see with the vaccine versus natural infection. So I would encourage folks, even if they have COVID, get vaccine. So vaccine is going to really help boost your immune response. As far as the children are concerned, I think we don't know whether the future strain is going to be much virulent to the children than the current strain. I think there is so much that we don't know about this virus, TJ, than we know. And even after doing for 19 months, and me and you have discussed multiple times, I'm humbled with this virus. Even though we can keep trying that, oh yeah, we got everything under control. No, there's a lot more that we need to learn from this virus. So we are sharing with you what we know. And that is science. I think a lot of people are saying, oh, why are you guys flip-flopping? Science is all about proving each other wrong. So once we have new information, we need to adapt to that. That is science. Otherwise, it would be a scripture, correct?
Yeah, and you're right.
We write a scripture at the first day of when the pandemic started. We just believe that scripture that we wrote that day that we're going to follow this. And I think that is difference between that and science. So I think for folks who are saying we are flip-flopping, we are not. As we get more science, we're going to first one to come say, hey, we apologize. We were wrong. This is the new science, and this is what we need to do. Janek, anything you want to add?
Yeah, and before you get into that, Dr. Patel, that was something that Dr. Kaiser talked about. He's spoken openly about, hey, we said this last March. I was wrong.
Yeah.
He said, we did not expect that. And he said it did not move the same. And to that end, Dr. Patel, as somebody said, you talk about we're here to, really a peer review actually is come here. Here's my study. Knock it down. And it's the one that survives that becomes the science at that point. It's the ones that don't survive that go by the sideways. Dr. Patel, you as I said, you're an infectious disease expert. I wondered though too how much of this has gone in. We have a lot of lay and social media doctors now. None of them had to go to school as long as you and Dr. Sharma did, or just that did. But but they've seen something online and stuff. How frustrating is that for you, sir, to see that? And someone may have a DR in front of their name. We don't know what that DR is, or what their expertise is. I mean, I think one of the most active folks out there kind of debunking stuff, trying to debunk stuff, is a veterinarian and puts DR in front of his name. And I just wonder how frustrating that is for you as somebody who's actually dealing on the front line with that, to see that type of thing going on.
Yeah, it's very frustrating.
And I'm sorry, Dr. Patel, your mic cut out on you there.
Can you hear me?
Yeah, now we can hear you.
Okay, all right. No, I mean, it's very frustrating. As a,
Well, Dr. Patel, we'll need to come back with you. The signal's trying to drop in and out. He was doing great.
Sure, I'll be happy to answer.
Yeah, I was going to say, Dr. Sharma,
Yeah.
I know, and I should point out, the two of you are, by the way, it's like having, and I will say this just on the side, because there are times I do it. It's like having Martin and Lewis around with these two guys sometimes, and they bring they're in stressful jobs, but these two guys, it's nice that they do have smiles on their faces, and they joke around a little bit when we need some levity on that. So should point out, but I know the two of you talk on a constant. Why don't you talk about that, Dr. Sharma? How frustrating it is as an expert in this.
Yeah, it is. I think it is very frustrating, and I think it is a disservice to the profession and to humanity in general. This is how I take these things seriously. I think one thing is that if you don't know, just don't say anything. And I think there are facts and then there are opinion, and you can't change your opinion to facts. So I strongly tell folks, there are facts and then there are opinions. Please don't convert your opinion as facts. So I think it is very concerning. I think all the association should take into notice. I saw some of those myself, and it is very concerning that even within some healthcare employees are doing this TikTok videos and showing things, and I don't think they have good understanding about the subject matter. Just like you said on veterinarian, yeah, they give ivermectin all the time. I give ivermectin to my dog. It's a great drug to get rid of parasites in the dog, but it is not a great drug to treat COVID. And you can always pick a case report or a case where everybody talks about, but when you look at totality of evidence on ivermectin, it does not work. I would be the first one to prescribe ivermectin if I think it works. It does not work. Same thing, the issue with hydroxychloroquine. I would be the first one to give it. But it's not working. So that's why I think people are biased, and there is none amount of evidence is changing their views. And that is concerning, that we can't talk to them out of this. They have to have some kind of experience themselves that said, you know what, I'm not helping humanity here. Let me think about it differently.
And that's, by the way, why we do this show and the ones with Dr. Kaiser. We know folks are going to be critical of it. That's fine. I welcome it, actually. Here's a good one. Beth Gall asks, I have a question. So if a vaccinated and non-vaccinated person go into the hospital with the exact same symptoms, are they treated differently? Like, is a non-vaccinated being treated differently as an extra precaution from that? And I guess it's per patient there. But in general, if someone comes in, they have the same symptoms, and you hear they're not vaccinated, do you kind of step it up a little bit with infusions coming one of the big things now too, Dr. Sharma?
Yeah, so we treat both vaccinated and non-vaccinated. Every person is a human being to us, and they are a patient to us. Okay, we don't differentiate how we treat vaccinated or unvaccinated individual. It all depends what symptom burden they have. I explained to you that unvaccinated having much severe symptoms like typical respiratory failure, there is a set treatment protocol that we have. It's actually pretty straightforward. A lot of the time when we tell, how do you become an expert? So you got to treat about 100 patients by that disease, then you get an expert in that particular condition. And I told you, we've taken care of 7,200 patients. Pretty much most of the internal medicine doc are pretty good expert in taking care of COVID. So they probably took care of more COVID than any other condition that they will take care of during their residency right now. Their residency program is 3 years. So I think one of the things is we take care of in the same way. I explained to earlier, the vaccinated individuals who are coming in, they're coming in for something else and they are test positive. So we just monitor them. If they do not develop any respiratory symptoms or have desaturation in oxygen, the first treatment is always oxygen. Then we talk about remdesivir. Once you are on oxygen, we don't give antibody. Antibody is only in outpatient setting with moderate symptoms and some comorbidities. And that is how we are taking care of them inpatient. But if they get severe in terms of respiratory failure, the course is pretty much same. Remdesivir, dexamethasone, watch and wait in these patients.
Right. In fact, La Real Familia, remdesivir and resveratrol. I've not heard of that before.
Resveratrol is basically, what you get in red wine. And you got to
trust me, if that worked, I would have already had the cure.
Yeah, unfortunately, it doesn't work.
Yeah, and so There was one here that I thought this was a great question since I was talking about booster shots. Sharon Works said booster shots. One to get them. Is there a timeline? The FDA is going to come up pretty soon. In September is what's being shot for, and the recommendation is 8 months after. And Sharon said I was vaccinated second shot in April. I have Crohn's disease. Got my booster yesterday. Was it too soon for the protocol?
Dr. Patel?
Can you hear me now?
Yes,
Yeah.
sir.
No, so there are two groups of, suppressed. So your Crohn's most likely, or some other immunosuppressed. These folks, two doses to respond poorly. So
Dr. Patel, hang on for just 1 second. Can you get a little closer to your phone there? I think maybe I think the mic's kind of compressing out. Let's try that, see if it's a little bit better. So.
Let's try again.
Yeah, that's what it is, I think. Yeah.
Okay. All right. So what I'm saying is that Crohn's disease patients, like the person you're talking about, is very likely on immunosuppressive regimen. Those folks respond very poorly to the 2-dose, primary series. So third dose for them improves their, vaccine response. In that case, all you have to do is wait at a minimum 28 days after receiving your last dose of the first 2-dose series. So they don't have to wait for 8 months. Because immunosuppressed people are very different category. They need protection. They need better protection. Whereas other folks, their immune response lasts quite long. And it takes about 8 months now from the studies we are showing where the vaccine breakthroughs are occurring. So that's a different reason to give booster.
Gotcha. And we answered this. I mean, we had this answer a little bit a while ago, but it is about the Delta variant. What makes it more contagious? How is it more contagious? Is it suspended in the air longer? This is what we had talked about earlier. It is once it's inside that it's not what it's happening in the air makes it more dangerous. It is that, and again, if you could just quickly, Dr. Sharma or Dr. Patel, explain
I can just add in quickly. I know there are certain mutations on the spike protein that's now very well known. There are a couple of them actually that have led to its increased ability to infect a cell and also increased ability to replicate to a very high quantity. Because of that, it becomes much more aerosolized. If you have a lot of virus in your nose, you're going to release a lot more in the air and travel further. Nothing has changed about its characteristic in air itself. It's just the amount of virus that is spilled out. It's so much, it infects a lot more people around you, even at a longer distance.
And then let me get into, I'm trying to find another question here. Let's see. Because we have a lot of comments, but not a lot of questions. And this is for question time here. Let me get over here I'm looking for question marks. So my apologies, folks, because I thought I had one. Well, here's one. And I'm going to question this later. Say, can we listen to politicians, listen to these people about all things COVID? These are actual experts. They have no political agenda. They only want to save lives. They have data behind everything they say. They have science, lots of scientific facts supporting what they say. This is Catherine Ryman. And one of the things Dr. Kaiser and I are getting the discussion about too is that, there are some politics involved, but you're a state institution, so I don't want to get, anyone too much, but, eventually policies come down and on. But at this point, do you feel that maybe some of the rhetoric that's being said out there, and Lori and Dr. Batiste, y'all can chime in too on this because y'all see on the front line. Do you think it's hurting the overall effort to get people healthy?
Yes,
I think so, and I think folks should just take the governor's lead. I was telling today, the governor was vaccinated, and he got mild infection, and he got antibody. And I want everything that governor got. And I want everybody to get vaccinated and also get antibody. And I think we should, I think this was a good example for us that everybody has a choice, and governor made the right choice. Kudos to him that he got the vaccine, and the governor made the right choice that he had mild symptoms and he got breakthrough infection and he got the antibody. And we want that for everybody. And we want that for every Texan. So that is my plea to everybody. Just follow the governor's lead.
Gotcha. Lori, and you were saying yes. I wanted you to go ahead and finish your thought.
I just, talking to people in the community, talking to, there's a disconnect within healthcare workers as well. The politicization of the whole topic. And I second heartily the feedback from your commenter. Just listen to these guys. Listen to the science. That's what, when I made my decision to get a vaccine, I was hearing everything that's out there that in the news and from the vets and everyone else who is commenting on this, and saying that it's experimental, it's too soon, nothing's been tested, we don't know, it's going to go into our DNA, and all of the scare tactics that caused people to say, I'm going to wait. And as Dr. Sharma said, it's 0% or 100%. You don't die halfway.
Right.
And so, when I read the stories of the people who are in ICUs saying, please, I want the vaccination now. The vaccination is not going to help at that point. It's too late. And for that person in that moment, that just breaks my heart. And so I would, yes, please listen to the science. Trust the people that you've trusted your entire life to provide you with medical care. That's the part that I don't understand, is in this moment with this particular virus, people who have not had a history in healthcare or in medicine are choosing to question the people that they've trusted their whole lives to care for them.
Yeah, Dr. Peace, let me ask you, how frustrating is it for your nurses when someone comes in and they've that story? And I know some people may want to hype it up and that doesn't happen all the time. So, but I would think that we've heard this many a time. Folks have come in and said, give me the vaccine now, when they've have bucked that. But how frustrating is it for your nurses right now to hear what they're hearing?
It's very frustrating. Nurses by nature are here to care for everyone, unvaccinated, vaccinated. But when you hear these stories, they hit home, and the thought is, it's all preventable. And if people would just get vaccinated, it's all preventable. So that's the difficulty. That's the challenge that they're having.
Let me get a question we got here. I had not, of all the ones we've done for the last year and a half here, Christy Smothers asked, could getting the vaccine compromise a high immune system? Not a low immune system, but someone's got a really good one. Can it compromise that?
I don't think so. I'm not sure what that means. We are immunizing people against a variety of different, pathogens. I mean, we immunize children with almost 5-6 vaccines at the same time, and we know it actually improves their health overall. So, not sure what the concept of high immune system is, but if you have a normal immune system, you can always boost it up.
Yeah,
actually, you can boost it up simultaneously for many pathogens.
And we've got just a few minutes left here. A couple of questions I wanted to ask is that obviously one of the things that some folks talk about nurses, Lori, I wonder if you hear this, and Dr. Batiste, if you hear this a lot. We saw the controversy that happened and the lawsuit that happened with Methodist requiring vaccines of their frontline workers, their nurses and the like. And there were some that said, no, I'm not going to do it. I made my own judgment call. And Laura, you even kind of mentioned it happens in your own field with that. Obviously, as a state institution, UTMB can't do that. Mm-hmm. And I just wonder, though, how much that question comes up to you. But is that, and then I'm going to ask you that question, but then I'm going to ask Dr. Sharma, are you concerned about folks going to work for you that say, I don't want to get vaccinated? Because that kind of sends the mixed message if they're on the floor. But at least start with you, Lori, and also you, Dr. Batiste.
I have actually had nurses say that they're looking for a job. They want to work at UTMB. Do we have any plans to have mandatory vaccination?
Yeah.
And my response is not at this time. So, we're hiring, And if people want to apply, they apply. We don't ask if you're vaccinated or unvaccinated.
No.
Yeah.
And, Methodist stepped out early with that requirement. Memorial Hermann has done the same. And so it's not part of, as you said, as part of the state. That's not something that at this time that we're doing. And so it's not part of our interview process. We don't ask people about that. And we just, introduce them to Drs. Patel and Sharma as they enter the building as a new employee and let them start working their magic.
But it gets into a healthcare question, though, Dr. Sharma.
Yeah.
And I've heard this from many folks that say, hey, I don't want to go get treated somewhere where someone's not vaccinated.
So here is the thing. I think we have taken care of all our employees and patients when we didn't have vaccine. So one thing that the work Dr. Patel and his team did, we know what the proper PPE is, how we want to wear the mask, how do we take care of patient. I can tell you with all the work we did, pre-vaccine, there was very little outbreak within the health system. Most of the employees that got infected were outside the hospital setting, not while they were taking care of the patient. So we know how to protect our employees and patients by masking. Now, the thing is, we can protect the patient as with an unvaccinated employee or the vice versa. But I still think that we're not going to be able to protect you with PPE if you get COVID with severe disease, if you're unvaccinated. So that's the challenge with some of the employees. Another thing is we are not going to be able to make it mandatory until it is still under EUA. So think about that. Flu vaccine is a condition of your employment. We have to make sure that every employee gets that every year, or they could show the reason why they do not get flu vaccine because it is fully approved to use it, and we have to do it as a condition of participation with CMS, Medicare. So I think one of the things is things will change, and we have to follow the guidelines as well as the state requirement. And I think the part of the reason the decision from the governor came because it was still under EUA. So it is hard to make things mandatory when you are still under EUA, and that's the reasoning behind it.
And let me get into this question here. You've kind of answered it beforehand. If you are vaccinated, why are you worried about me being vaccinated? You should be safe. It actually doesn't work that way. You had pointed this out, Dr. Sharma, and also you, Dr. Patel, that it's when you're unvaccinated, that's when the mutations can happen.
Yes.
Correct?
I think, look, this is a global pandemic, right? The biggest disaster you are going to face in your lifetime. If you want to end it, we have to do it together. It's not an individual decision just to protect yourself. It is to protect others around you. Okay. So if I'm vaccinated, if everyone is vaccinated around, we're going to stop this pandemic. So, vaccination is everybody's responsibility to protect the next person around you. And again, Dr. Sharma had already emphasized that if we stop this virus from passing from one person to another, it will stop mutating. We got rid of smallpox and almost polio, and we don't hear of mutations of those viruses because they don't exist anymore. So I think to end the pandemic, we got to do this quickly, and we got to do it simultaneously.
And you bring up polio, and that's a good one because I know early on in this, that was one of the conversations that Dr. Raymer, Ben Raymer, the interim president of UTMB Health, and I had, was about the early days of the sugar cube and then the shot, and I'm a Rotarian, so that's you actually learn more about dealing against polio and the fight against that, and is essentially eradicated, except in parts of the world in which no, we don't trust the vaccine. I just wonder, knowing what we know about polio, smallpox years ago, if we had what we're seeing now happen then, how disastrous would that have been?
Yeah, I think no, but I'm concerned now, TJ. We have great examples of diseases we have eradicated with vaccine, right? It's one of the biggest advances of science. One of the biggest reasons now we live longer than before. So, I'm afraid that I think with social media influencing a lot of people in the wrong way, that we would actually also look at any other emergency or threat we face in the future with same amount of skepticism. And I don't think we're going to go that far with that kind of approach. So I'm afraid it's going to have some long-lasting legacy beyond this COVID, how people interact with science, with medicine, and they make their personal choices. We got to change this.
And here's a question. I had not gotten this from anyone yet. What are effective treatments a person can do at home?
Sure, it all depends.
It kind of depends, right, Dr. Sharma, on this?
Yeah, it all depends. So I think if in general, there's always this discussion of vitamin C, vitamin D, zinc. You know, people have talked about it multiple times. I think they are good if you want to just, you know, be healthy and take multivitamins, take vitamin D. If your vitamin D is low, it is good. But we have not seen any benefit of actually using vitamin D when you have to treat the disease. Even person who have low vitamin D, giving vitamin D in the hospital setting did not show any improvement in outcome. I agree that sleep is very good in terms of improving your immunity, especially innate immunity. I think walking into the forest, which is actually a great idea. If you have forest around, you can go, and we have talked about it. It helps your innate immunity. Those phytanosides within the forest, it actually boosts your innate immunity. So we don't have that many forests around where we can go for a walk, but it is actually good go for a walk, then sleep well. And then there is this whole idea about helping your immunity with cold and hot shower, alternating cold and hot shower, and then sitting in a sauna. Those are just good practices to help with your immunity, help your well-being, but it is nothing to do with to treat COVID. For COVID treatment, we have already said what is currently approved, that monoclonal antibody, if you have symptoms in an outpatient setting, when you get hospitalized, basically the main thing is oxygen, hydration, remdesivir, dexamethasone, and there is another drug called tocilizumab that we can use. So that is kind of where we are. We've talked about it, you know, people want, you know, these whole thing about snake oils, and we talked about bee stings, you know, that is something. You know, these are good just in general for improving your innate immunity, but I think this impact on having COVID is not there.
Yeah, I'm not going to go get a bee sting to make myself feel better. I can tell you that.
TJ, if I may add.
Yes, sir, Dr. Patel.
Yeah, there are also clinical trials going on with oral medications that are antiviral, you know, analogs of remdesivir. If something like that works, I think it would become another option. Because right now, truly, as Dr. Sharma is saying, for outpatient milder disease, we really don't have any effective therapy. Unlike, let's say, for flu, we use statin, right? For herpes, we use acyclovir. We really don't have effective antivirals for home-based use before you progress to worse disease. So now this virus is probably not going to go away anytime soon. So I think there will be enough time to develop this thing over the next 1 year. Perhaps we may have something available if it works through clinical trials.
Yeah. And I'm trying to find the question here because it comes into the basic question was from one of our viewers was, what's it going to take here it is. This is the question. Bonnie Hazelwood. What determines whether or not we will have to live with COVID like the flu or to be able to eradicate it like polio?
So I would say my answer would be we have to live with the COVID like flu. It's not going to be eradicated. The key is right now, if you look at US, we have 600,000 people that die with COVID, correct? You know, bad flu season, 60,000 people die. Bad flu. Okay, bad flu year. So once we get to less than 100 deaths during that would be the ideal time for us that, okay, you know, this is part. And I always said there is COVID, there is nothing post-COVID. You know, it's going to be just pre-COVID and COVID. That's going to be our new lifestyle, how we have to live through it. That's why how we have taken care of these patient and inpatient setting. But the volume is so high. And TJ, it seems like there's like cognitive dissonance going on everywhere. When you go to the beach, seems like everything is fine. You come walk to the hospital and you think that it is a different world. And I just think that people need to realize what we deal with in the four walls that people don't see versus what's going on in the beach is very different.
Right.
Janek, thoughts from you?
No, you are right on the dot. I mean, absolutely no. there's a disconnect between alternate reality people live in the world, and people go around shopping and everything is fine. And here we are in our hospital changing policies and procedures and, dealing with crisis and everything. It's just so much disconnect between the two. But again, I think this virus is so humanly adopted, TJ, it's not going to leave us. It's the most adopted virus we know right now. In fact, of all viruses you combine, such virus will never leave the human population. So what will happen is, obviously, we're all naive to this virus. So it's going to go around, infect everybody, or unless you are vaccinated. But in the future, it's going to keep a certain presence at, vaccinated people will get mild illness, immunocompromised people might get into trouble, elderly people might get into trouble, new children will be born, before they get vaccination, they might get infected. So certain low level, high risk population will always remain, just like flu. But vast majority of people are going to be protected through vaccination.
Thank you all for coming on today and coming into the evening. I know we talked about, I said it was going to be 45 minutes. I meant to say an hour and 45 minutes, Dr. Sharma.
I know.
Sorry about that. I mean, but it's fascinating. As Dr. Sharma and Dr. Patel know, I pick their brains a lot every time I'm around them. They run away from me now when I come up. And Dr. Batiste and Lori, thank y'all for coming on as well. And good luck to y'all on recruiting.
Thank you, TJ. Thank you for all you're doing.
In fact, what we're going to make sure to help out Lori is some more here. There's the QR code. You're looking for a job.
Thank you.
Use it.
You could use some help over there. She could use the help. Scan, get a good job. If you get a good Galveston job, you get to look at the beach every day.
Yep.
And thank you all for coming on with us here today.
Thanks,
we'll be back next
you,
month. As always, Dr. Kaiser is back with us next week. He's taking a break this week, but he'll be back on with his weekly visit with us as well. I'm TJ Alts, I-45 now.
Bye.